All right. So I want to talk about organophosphate toxicity. Some of this will overlap a little bit with Dr. Tran's lecture that she gave earlier, but the slightly different focus. What do I do? Click. So I feel like usually when organophosphate tox lectures are given, it's always with the case example of some farmer who spills pesticide on himself and then shows up to the ED to get treatment. Then we talk about the mechanisms and antidotes and all that stuff. But I wanted to talk about a situation that we might be a little bit more likely to encounter working in like big urban centers, which would be like an organophosphate mass casualty incident, which unfortunately there is some historical precedent for, like Dr. Tran mentioned earlier. Tokyo 1995 was the largest civilian population exposure to sarin gas, which I'll talk about a little bit more. And unfortunately, more recently in Syria and elsewhere in the Middle East, these things have happened as well. Wanted to focus a little bit more on the Japanese example, just because I think that mimics our environment and resources a little bit more. 1995, this Om Shinrikyo cult released sarin liquid, technically, that evaporated into gas on 3 lines of the Tokyo subway during morning rush hour when trains are at about 200% capacity. When it was all said and done, there were 12 deaths, 6,000 injuries. In one nearby hospital, St. Luke's, received 600 patients in 1 hour. So I thought that presented some kind of interesting questions, right? That's a lot different than 1 or 2 farmers showing up to your emergency room. 600 patients with all sorts of varying symptoms is going to present a lot of mass casualty considerations. So I wanted to talk about, the things we consider in any MCI, kind of in the context of organophosphate poisoning. So how do we really figure out who's sick, who's not sick, who needs antidote immediately, and how do we actually treat those patients? So again, sort of reviewing just briefly some of the pathophys. We're talking about acetylcholine, main neurotransmitter of your parasympathetic nervous system, gets released, binds to its end organ receptor, and in order to get inactivated, needs to bind to acetylcholine esterase, so it can be cleaved and inactivated. Sarin gas and these other nerve agents bind acetylcholine esterase with really high affinity, and they bind like covalently and permanently, causing a pretty immediate, drastic increase in your acetylcholine signaling downstream. And again, this happens at both nicotinic and muscarinic receptors, and they're referred to as nerve agents because they do have a slightly higher affinity for the nicotinic receptors at the neuromuscular junction. Just in general, right, our nicotinic receptors are at the preganglionic junction of both sympathetic and parasympathetic, but the one that's probably most clinically significant is right at the myoneural junction there. So we have acetylcholine released from our somatic nerves, binds to the receptor on the muscle, activating like muscle contraction, which leads to the kind of fasciculations that we can see in these patients and eventual paralysis. Everything else is from the muscarinic receptors. And that leads to basically the secretion syndrome that we talked about a little bit earlier today. So we'll get pupillary contraction, lacrimal gland tear production, drooling from the salivary glands, bradycardia in your heart, vomiting and stomach secretions, colonic secretions, diarrhea, and bladder contraction leading to the urinary dysfunction that we see. And again, right, a billion different mnemonics for this. I like to think of it as just secreting from everywhere. The only thing we have to really think about is the bronchorrhea and bronchoconstriction and the pupillary constriction. Those are the ones that don't really, I guess, fit into the secretion model. So imagine we have 600 patients showing up with some combination of this, and we probably don't have enough atropine in the hospital to just give 600 patients. So do you pay more attention to the sweating and pooping patient or the vomiting and peeing patient? Who gets most of your attention? This is the stat model of triage. This was, I think, designed more for bombs, blast injuries, gunfire, stuff like that. We don't have to go through the whole thing, but the point I think that I want to get across is that the very first branch point kind of determines everything. It's basically, are you breathing or are you not breathing? If you are, you get sent down some pathway where you'll get treatment at some point. It's just a matter of if it's immediately or a little bit delayed. If you're not breathing, you try to position the airway one time. If that doesn't work, you're declared dead or expected, and you're not going to be allocated resources or treatment. But that should probably be a little different for a chemical attack, right? These things that we have like antidotes for. We don't have antidotes for blast injuries and gunshots, but if we have an actual medicine that can reverse the pathophysiology, you might have to think a little bit differently. A lot of text that we can ignore. There's no official triage model for chemical attacks, but this is one that was proposed. And again, the main takeaway, I think, is that in the expectant category, when in other MCIs, these patients might just be kind of left for dead. Most of these proposed models still call for aggressively resuscitating and treating these patients with the available antidote within reason. And there's a little bit of historical rationale for this. The St. Luke's Hospital in Tokyo had a little write-up of 5 critical patients that they received. 3 were in cardiopulmonary arrest, 2 in respiratory arrest. One of the cardiac arrest patients got ROSC, spontaneous breathing, within 5 minutes, and was actually discharged on hospital day 6. There was another patient who similarly achieved ROSC pretty quickly, but died a month later. I think the one that survived was a relatively young, healthy woman who was actually seen like exiting the station and then collapsed and brought to the hospital. And then the respiratory arrest patients were both discharged on hospital day 3 and 4. And on the flip side, right, if there's a lot of patients, you're going to have to, more or less ignore. These are the CDC guidelines for atropine dosing in these patients. Again, the takeaway is kind of in that top row there. Basically, if there's just isolated pupillary constriction and even a little bit of vomiting, these patients don't need immediate like antidote dosing. Whereas anything above that is probably going to require atropine. And knowing them, you don't really have to think too much about the different combination of symptoms. The main trigger for giving therapy here is going to be like wheezing, bronchuria, dyspnea. That should be an automatic trigger for giving atropine to these patients. And again, a little bit more historical backup for this. Of the 6,000 injuries in the Tokyo attacks, 4,000 were just isolated ocular symptoms. So they showed up being like, my eyes feel weird, I have blurry vision, and nothing else. They were just decontaminated, observed for a little bit, and then sent home. And then for the rest of the breakdown, close to 1,000 moderate, so basically additional symptoms, but didn't need mechanical ventilation. 50 patients need to be intubated, and 12 died. So again, just sort of reviewing what to actually do once we decide to pull the trigger for treatment here. Atropine, again, is a competitive muscarinic antagonist. I kind of had to remind myself many times, it doesn't really act on the nicotinic receptors at all. So you'll see a reversal of most of the symptoms, hopefully. But if a patient's like fully paralyzed or has a lot of muscular symptoms, that probably won't improve very much. 2 to 4 milligrams, basically however you can get it in, doubling every 5 minutes until full atropinization is achieved, which should theoretically be followed by an infusion of 10 to 20% of the effective total dose. Atropine has pretty good CNS penetration, so it may help with the seizures and kind of neurologic effects that you can get from this. Then there's Paradoxine, which Dr. Tran spoke about a little bit. In theory, it's supposed to catalyze the reactivation of the acetylcholinesterase enzyme, kind of separate it from the serin or the agent that is bound to it, so it can work to cleave acetylcholine. Just 2 grams IV or IO over 5 minutes. Doesn't really get into the CNS at all. These patients are pretty prone to having seizures. Basically, just benzos is the recommended treatment for it, and you may need to give pretty high doses for this. Talked about this a little bit. The 3 Bs. This is really what you're monitoring in your treatments. Vitals, you want a heart rate above 80, blood pressure above 80. That's always nice to see, and clear lungs. A little bit of actual evidence behind the dosing and where it comes from. There's a randomized control trial in Bangladesh, open label, 160 patients, mostly from organophosphate, a pesticide exposure, divided into 2 groups. I guess the old school way of doing this was basically just bolusing 10 to 15 minutes, seeing how the patient reacts, and based on your experience and preferences, deciding which doses to proceed with from there, versus a group that was just doubling dose every 5 minutes, followed by the infusion that I talked about. And then they measured atropinization by just unquestionable resolution of hypotension, bradycardia, or bronchuria. And the results are pretty striking, at least. The time to atropinization in kind of the old just feel it out method was 150 minutes versus just 23 minutes in the doubling dose every 5 minutes, followed by an infusion arm. Similarly, mortality 22% in the traditional method versus the kind of doubling infusion-based method. Paradoxine, on the other hand, there's, I guess, a decent amount of controversy about whether or not it actually does anything. There's a few different systematic reviews. I think one was, Dr. Wiener mentioned there's one out of this department, a recent one in 2020 that basically showed it really didn't give any difference in mortality or need for ventilator support. The only caveat to that, I guess, is that all of these studies are done with like pesticide exposure, because luckily there's not enough randomized controlled trials with nerve agents. So in the event of a chemical MCI like this, it is still considered the standard of care. But what you should really be rushing for is the atropine. So just the take-home points of everything, right? The main triage considerations I wanted to get across is these sort of recently arrested patients who may otherwise be sort of left for dead in other MCI situations can still be salvaged, at least in theory, with pretty good outcomes. Lone pupillary involvement likely only requires just observation. Wheezing, shortness of breath, anything beyond that is just kind of an automatic trigger for atropine therapy. Doubling dose every 5 minutes until clear lungs, followed by an infusion. This is sort of what our best data has to show. Paradoxine, great if you can find it, but don't lose your mind scrambling for it. Then obviously something we didn't really talk about, kind of the logistics of getting these patients to the hospital and everything, but PPE and decontamination are kind of the very, very top priorities here. That can pretty quickly turn a patient with, moderate symptoms into minimal and severe into moderate. And re-triaging these patients is very key. If this happened in the subway station, a patient walks in and only has ocular involvement, that can pretty quickly progress to severe disease if you don't keep an eye on them. But that's it. Any questions? Cool.